Welcome to the Long COVID podcast with me, Jackie Baxter. I am really excited to bring you today's episode. Please do check out the links in the show notes where you can find the podcast website, social media and support group, as well as a link to buy me a coffee if you are able. You should not rely on any medical information contained in this podcast and related materials in making medical, health-related or other decisions. Please do consult a doctor or other health professional. I love to hear from you. If you've got any suggestions or feedback or just want to say hey, then please do get in touch. I really hope you enjoy this episode, so here we go. Welcome to this episode of the podcast. I'm very excited to have Eddie Duncan with me this morning from Stirling University to talk about a research project that he's involved in. So welcome to the podcast. Can you introduce yourself a little and explain your role at the university?
Thanks, Jackie. It's a pleasure to be here with you today. So thank you very much for inviting me onto this podcast. So I'm Eddie Duncan. I work at the University of Stirling in the Chief Scientist Office for Nurses, Midwives and Allied Health Professions in a research unit for them. I'm Professor of Applied Health Research, but my background is as an occupational therapist, and I've worked for the last 20 years or so in applied health research in a variety of fields. When COVID struck, we were very involved in different studies related to the acute phase of COVID. I work very closely with the Scottish Ambulance Service and with ambulance services across the UK, so we were very involved in work with ambulance services and also looking at the mental health impacts of COVID through a different Scottish Government-funded study. And then this opportunity came up to look at long COVID. The Chief Scientist's Office launched some funding for long COVID research, and myself and colleagues across Robert Gordon University and the University of Dundee, as well as clinical academics in Ayrshire and Arran, put in a bid to study long COVID community rehabilitation, how that's being delivered in practice, because there's so much we need to learn about that. So that's how this work came about.
Fantastic. So could you give us just an idea of the others on your team and the different areas of expertise involved?
Oh gosh, there's a long list. It's a big team, so I'll try and go through that. But it's worthwhile talking about the different expertise which they bring, because a study like this is quite complex and really needs a whole range of different perspectives to be on board with it. So there's myself, who comes from an applied health research perspective, but is also an occupational therapist. And the other co-lead investigator of the study is Professor Kay Cooper, who is a clinical allied health professor up at Robert Gordon University and is a physiotherapist by background. So very, very strong clinical AHP link there. And that continues amongst our co-investigators as well. So Dr. Jackie Morris from University of Dundee and Dr. Jenny Preston, who's a clinical academic based in Ayrshire and Arran, but has an associate professor's post at the University of Stirling. So Jackie's a physio and Jenny, like me, is an occupational therapist. So at its core, there's a strong allied health professional research group, and you'd expect that for a rehabilitation study, because these are among the professions who are central to the rehabilitation process. As well as clinicians who are academics, we also have some statistical expertise from Dr. Paul Swinton at Robert Gordon University. And we also have all got some very strong clinical expertise in long COVID from Professor James Chalmers, who's a consultant at the University of Dundee, a medical consultant, and giving us a lot of specialist long COVID expertise involved in large UK studies around about long COVID as well. And also Dr. Lindsay Alexander, who's another physiotherapist based up at Robert Gordon as well. So a large clinical team there and with some statistical expertise, but very central to the team. And although mentioning them last is only really to highlight them, is the group of people with lived experience who form part of our team as well. So we have 3 individuals who have been with us since the beginning, really, of this journey as we've pulled together our application. And they meet with us monthly to go through where we're progressing and to give their lived experience insights. And really, they're an invaluable group of people. I really want to pay credit to them, to Fiona Smith, Alison Despard and Jane Ormerod, who have all provided fantastic input and ongoing input to our study. So that's the team.
Fantastic. So yeah, you've got a big variety of expertise, but also of geographical spread as well.
Yes.
So that helps with the different areas that you're looking at?
That's right. It's a Scottish-wide study. So towards the end of 2019, the beginning of 2020, we surveyed all of the health boards in Scotland and asked them what they were providing for people with long COVID in terms of rehabilitation at that time. Obviously, the content of that has changed quite a lot over the last year. And what our findings were then was a snapshot picture and is very different in some ways to what's being provided now. But what it showed was that there was quite a large degree of variation across the health boards in Scotland at that time. There was only one, and it's still true, there was only one unique service set up for long COVID at that time, the Cares Clinic in Tayside, in NHS Tayside. And the other health boards all replied that yes, there was the potential for community rehabilitation across all of the different health boards. But at that point, and we were still in lockdown, if you remember, they were being provided in quite different ways. So some clinicians were providing face-to-face input, others were doing it digitally through near-me consultations. There's also real challenges in Scotland because we have a remote and rural population as well as areas of urban centrality. So how you deliver services for the emerging at that time condition of long COVID across that wide range of different settings is quite a challenge. So we used that information in our bid for the study, which was funded, to highlight 4 different health boards which we would use as case studies. And we chose them on the basis of how they were providing long COVID rehabilitation at the time that the grant was put in, but also recognising the different geographical challenges which each of these different health boards provide. So we've got NHS Grampian, NHS Tayside, obviously with the Cares team there, NHS Lanarkshire, and NHS Ayrshire and Arden. As you said, quite a large geographical spread, but very purposefully chosen to get a mixture of urban and semi-urban and remote rural communities.
Because like you say, Scotland is very different in different areas, which is one of the attractions of it, I guess. But when you're looking at one size fits all, it maybe doesn't.
When you're looking at delivering, and it's not unique to long COVID by any manner of means, but when you're looking to deliver services, the different geographies and population densities of the country give rise to challenges. And that's part of what this study is about we're taking an approach to look at what works for who, in what circumstances, and why. So it's not a trial in its traditional sense, absolutely not, because we don't have a definitive treatment for long COVID rehabilitation. We really are learning as we're doing at the moment. There's lots of pure science studies happening, but what we were particularly interested in was learning as we were doing what was working for people, in which situations and why, and could we use that to, as quickly as possible, disseminate that information to other health boards across Scotland so that they can all share from the learning that was happening within this study. So we have inbuilt learning sessions with the other health boards at different time points within this study.
That's really useful because, like you say, 2 years is quite a long time, isn't it, to wait for results?
Yes.
So I think you've just talked through some of the study. Is there anything else about how it will work?
So the study is what we describe as a mixed methods study. That means we're collecting different types of information in different ways to answer different questions. We're very much interested in looking at patient outcomes, so understanding are people improving through community rehabilitation. And we're measuring that by asking 100 people in each of these different health boards, so 100 in each of the 400 in total, to complete some outcome measures for us at baseline, at the end of their rehabilitation, and at 3 months follow-up to see if there's any sustained change in that. The sorts of things we're measuring, we're using very standardised measures which are being used across a whole range of long COVID studies at the moment. You wouldn't be surprised. Things to do with fatigue, to do with respiratory, to do with function in everyday living, and to do with mental health and cognitive challenges as well. So across the broad range, there are so many different symptoms associated with long COVID, it's impossible to measure absolutely everything. But we hope we're picking up the key features that are associated and are becoming more and more evident to be associated with long COVID and measuring those outcomes. So the first strand of data that we're collecting is outcome measurement for patients. But we really also want to speak to patients themselves and to conduct qualitative interviews with them, where we'll ask them about their experience of engaging in long COVID community rehabilitation, what's worked for them, what they found more challenging, what could be improved from the service. Do they think we're addressing their needs? That kind of question. It's also really important that we ask staff of their experience, because this is a very new experience for clinicians to work in long COVID. So there's a lot of learning going on at the moment, and we want to capture that learning so that, as I've said before, we can disseminate that across services as quickly as possible. So we're doing interviews with a whole range of clinicians in each of the different health boards at different time points, because one of the challenges for us is that not only is our understanding of long COVID rapidly developing, but also how services are being delivered is rapidly developing. As government funding is announced and health boards are beginning to look at what to do with that, then actually what the service looks like is changing dynamically across the whole of our time period of the study. So one of the big challenges for us is to keep up to date with that and to make sure we're capturing all the learning that goes along with that.
It's changing every week, isn't it, almost? So yeah, that must be pretty difficult to keep up with. When you're talking about how you're taking results sort of all the time, what have you discovered so far?
One of the challenges of research is actually getting all the permissions in place and getting started. So although we got funded in April, we're just beginning our data collection now. So unfortunately, I don't have any exciting results that I can share with you at the moment. We have literally just started collecting data from people in the last few weeks. So it's too early to give any findings at the moment, but you'll appreciate that for good reasons and for patient safety and good governance reasons, we have to get ethical approval, and then we have to get governance approvals from each of the different health boards, and that can take longer than most people realise. So we've just started data collection in the last few weeks.
Yeah, fantastic. I think it's really important that you are putting the lived experience and patients at the centre of it. I think the lack of government listening to the lived experience has been very frustrating.
So good research these days always places their patients, their participants at the centre of it, and increasingly the importance of co-constructing research with participants of whatever type, but in this instance, people with long COVID, it's a no-brainer, really. They absolutely have to be at the centre, and we've really, really benefited from the conversations, because not only do the people with lived experience are they able to critique the work that we're doing, but they're also able to feed in their own patient journey, which gives us such a richer and more in-depth understanding of what it's like to be living with long COVID. So it is very important. One of the things we did find throughout our approval process, though, is that while at our survey in the end of 2019, beginning of 2020, indicated that services were available for and being delivered for small numbers of people with long COVID across Scotland, actually in the health board areas that we've been having close conversations with, it's evident, and it's changing all the time. But it has been evident up until very recently that the patient flow, if you like, people coming in for community rehabilitation, the numbers were very, very low. And when you look at around about 80,000 people in Scotland who are believed to be living with long COVID, it just didn't make sense that not all of them will need community rehabilitation, not all of them will be appropriate for community rehabilitation. But if only 10% of them fitted the criteria for that, then we should be seeing thousands of people coming through these services across Scotland, which would indicate that we should be seeing hundreds of people coming in to the services that we were working with. And that simply wasn't happening in practice. Now, we don't have all the answers to why that is. So I'm speculating now. This is not built in data at all, but it's very much built in speculation. But if we look at a service like the CARES team in Tayside, where we know there's a dedicated long COVID clinic, it's been very well publicised. It's received national and local publicity, so people know about it and GPs know about it. They have a very large waiting list of people to be seen. The team themselves are not as big as they would like to be. But in other places where there hasn't been the same publicity, then you're not seeing the same degree of pressure on service and waiting lists at all of people with long COVID. So it leads you to think that the whole communication of availability of services is an area which could be improved quite substantially. And I hope that with this additional funding which has been announced in recent weeks, that is something that will improve dramatically in the weeks to come.
Yeah, because it sounds like the referrals aren't really happening because maybe the GPs don't realise where they should be referring people to almost.
I think that is a real challenge. We don't have the data to support that. But when you look at patterns of referrals where the communication pathways are good and patterns of referrals when the communication pathways are not so evident, then that's the conclusion that it leads you to.
Absolutely, yeah. There don't seem really to be that many clear pathways for GPs beyond the nice and the signed guidance.
So guidance is great, but it doesn't tell you where to make the referral.
Yeah.
Scotland was at the forefront of developing that guidance at quite an early stage together with NICE and SIGN. But the implementation of that is all important. And it's the implementation that's going to be crucial in this next phase too.
So almost there's sort of disparity between what the health boards think they're providing and what patients feel that they're actually being offered.
Well, I think the health boards know what they're providing, so it's not just that they're thinking about it. There is provision there, although certainly when you speak to clinicians in health boards, there's an acknowledgement that they also have to develop their capability and their capacity as well. Some of these services, if we think of respiratory physiotherapy, for instance, which can provide already existing therapies which seem to be very useful for people with long COVID. So there are things out there which work, but often across health boards, the numbers of physiotherapists who are trained to provide that is relatively small. One of the big challenges for health boards is that when you do provide the clear pathways and tell people where to refer, there's going to be an almighty influx of referrals, and there just won't be the capacity to meet that demand. Now, hopefully, the increased funding that the Scottish Government is now providing will achieve that and will develop that. But within that, it doesn't happen overnight and by magic. Health boards have to train up clinicians who can absolutely be trained up. They've got the core skills to do it, but it's more complex than just flicking a switch and saying, oh, now you have the money, everybody can come. You have to develop these pathways. You have to skill up your staff who are already, frankly, very busy with their existing workload. Rehabilitation is not an area of the NHS which has received a lot of funding over recent years. So it's not that there's a massive skill set there waiting to deliver therapies for people. In fact, quite often the teams are quite small. So it's quite complex to build it up. And I know that health boards across Scotland are working on all these issues at the moment. But it's certainly true that what health boards can deliver and what people either know about or know how to access, there seems to be a bit of a disjunction there. There's a bit of a problem there.
Yes, and of course, health services so under pressure from so many different areas. And then if you think about the number of doctors and nurses and physios that are now off ill because of COVID or long COVID or something else, it must be feeling the pressure from everywhere.
You just need to open a newspaper or a website every day, and the pressures of the NHS are front and centre of all of this. And it's not unimportant. The context in which we're trying to develop these long COVID services is in a health service which has never felt more pressured than it has at the moment. So it's bound to be challenging.
You mentioned earlier there's a lot of variation in what health boards are currently offering, and also the disparity in population. So you have areas such as Highlands, which is quite dispersed, and somewhere like Glasgow that's much more condensed. Is there going to be a need to have different approaches in different areas?
It's a really interesting question, and is at the core of what our study hopefully will manage to describe and pick up on. It will depend a little bit how the services and the different health boards go on to develop what they're delivering. So it's not that we are delivering something in a health board. We're studying what the health board decides to deliver. So we don't have control over how they do that. But if you look nationally, I'm talking about the UK now, there's been very different approaches to how to deliver rehabilitation and other long COVID services across the UK. So England has got this very high profile early investment of a large figure, at 33 million, I can't remember. But actually, when you break that down across the English population, that is not as great as it sounds. So they're developing long COVID clinics, centralised long COVID clinics. I'll come back to them in a minute. Wales took a different approach and have decided to invest within existing services, so to reinforce existing services with funding to have the capacity to do long COVID rehabilitation and other long COVID services. And the announcement in Scotland by the Health Secretary and First Minister a few weeks ago took a very similar approach to Wales, where they're arguing, instead of mirroring what's being set up in England, preferring to reinforce existing services. The answer is we don't actually know which of those models is better. And our study and a larger study in England at the clinics there are aimed to try and understand that. And we will be able to do that to a certain extent because services like NHS Tayside, which is not the same by any manner of means as the long COVID clinics in England, it hasn't had the same funding behind it to date, but is a bespoke service for long COVID. So that's quite different from, say, NHS Grampian or NHS Ayrshire and Arran and others who seem to be using existing services. And certainly that's what the government would like them to do. We don't know which is best, but I can see the logic of investing in existing services. From a lived experience point of view, it might seem very attractive to have a long COVID clinic. It's badged well, it looks great, that's just for me. But there's huge problems of people in remote and rural communities having access to those. So if they were to be a face-to-face thing and not a virtual thing, they would be based by necessity in large urban communities. So how do you access that if you're remote and rural? And often, if you look at what's happened in England, although it sounds very, very attractive, they all look very different. So some of these clinics are kind of platinum plated, one-stop shops with lots of HPs. You go in there, you see everybody, it sounds wonderful. But several of them are virtual clinics. You don't actually get to see anybody face-to-face at all. So it's always worth drilling down below the headlines to understand what's actually being delivered. If you have a bespoke service, you have to think about having accommodation for that. Where are you going to put that? What's the infrastructure for that going to be? It all has to be created. Whereas if you invest in existing structures, then you have some of that infrastructure around you to build on. And you also have access to some of the expertise. So you can tap into those people who are the respiratory physiotherapists with the expertise in that area, rather than being distant from them and perhaps having a less skilled workforce who's just newer to the area. You can tap into a lot of expertise. So I think there's good clinical reasoning for arguing that investing in existing services and really supporting them to deliver long COVID rehabilitation is better than having a bespoke centre. But we really need to look at the data and understand over time if that's true or not.
Yeah, absolutely. I guess the setup cost for a long COVID clinic, you're going to have an awful lot of money going into that before you even start looking at the actual services.
And from the lived experience perspective, it's probably also going to take much longer to set up as well. So you could imagine it would be easier to set up pathways for people with long COVID within existing structures because a lot of the infrastructure is there. It could take much, much longer to get these centres set up.
I guess it's not necessarily a one-size-fits-all either.
No, absolutely.
Long COVID patients in Scotland have been calling for some sort of joined-up multidisciplinary care for a long time now. I mean, I think the rationale behind that being that ill people struggle to juggle the many different specialists themselves. You know, if you've got a cardiology appointment and a respiratory appointment and then, you know, something else and something else, people who were very ill are really struggling to manage that. Whereas I guess the beauty of going to a long COVID clinic is you go in and you get all of your things, if that is what happens, because like you say, that may not be the case. That's the ideal, I guess.
It's really interesting because living with chronic conditions, these challenges that people with long COVID are facing and articulating very well, and you're not wrong at all. These are all challenges of having to deal with multiple conditions and multiple different professionals. But people with chronic health conditions or ongoing health conditions have been articulating these problems for many, many years. And my inbox is, I wouldn't say full, but you know, I get several posts from people with other chronic health conditions who say, gosh, if you can solve this for long COVID, please could you also bring it into MND, chronic fatigue, all sorts of other conditions where people have struggled for some time with exactly the same challenges. So you're absolutely right, it is a challenge. And I guess what I hope is that some of the learning that will come out of this study and other studies around long COVID and rehabilitation will have learning not just for the population who are having to live with long COVID, but also for the population of people who are having to live with chronic health conditions in general.
Absolutely, yeah. And long COVID has sort of hit the news in quite a big way at last because the sheer number of people at the same time. But as you say, I mean, there are so many people that have been suffering for so many years.
There are so many, and I'm not setting one up against the other for a second, but I think it is a sort of somewhere between frustration and possibly jubilation. I'm not sure for other people that these issues are now getting such prominence. You know, frustration because for so many years, populations of people have been saying the same thing and feeling they've been unheard of. And now all of a sudden, just because of the sheer volume of people living with long COVID, it's become such a prominent issue. And jubilation possibly isn't the right word, but I think you understand what I mean. Happiness, you know, satisfaction that at last these issues are being taken seriously.
Yeah, and we have to hope that one will help the other.
Absolutely.
If we find a way that will provide rehabilitation in a better way for long COVID, then why couldn't it also work for others?
That's right. I know that members of my research team feel very strongly that this is a fantastic opportunity to develop an evidence base to support rehabilitation in general, as well as specifically for people with long COVID.
Yeah, exactly. Yes. I think this has brought home to so many people that there are a lot of things that could be done better. So yeah, it is an opportunity.
They are very complex issues. You know, if it was easy to fix, it would have been fixed already. So some of these issues are very complex, and our study will provide some of the answers, I hope, to this and some suggestions as to what to do. But the health service has struggled for many, many years in providing that joined up seamless service within health, never mind across health and social care, which is the other place where you find that this connectivity of services really struggles. So I hope that findings of our research will go some way to helping that move forward.
Do you have plans to extend the study?
One of the things which we're looking at the moment is obviously so dynamic. And the study started quite a long time before the Scottish Government announcement for funding. And we were part of various voices calling and pushing government to announce funding for long COVID rehabilitation. So we were delighted when they in fact invested £10 million for long COVID. the time there was a lot of people saying, oh, £10 million, it's not very much, is it? What would be enough is a really interesting question. More is always better. So I'm not suggesting that £10 million is enough. But if you look at the populations of England and then of Wales and what they're investing in their services, and look at what Scotland is investing, it's more per head of the population considerably than England, and by a little bit than Wales as well. I can't remember Ireland, but I think it's more than Northern Ireland too. So relative to the other nations of the UK, Scotland's contribution is above the others per head of population. Why am I saying all of that? Because the next important thing is, how do they use that money? That money will be given to each of the health boards to invest locally as they see fit, and I think that that's very, very important. What's also important is the decision-making process about how that money is distributed within the health boards and which services it goes to support. So at the moment, we're looking to see whether we can extend the study by having some quite high-level interviews with key stakeholders at the health board level to really try and understand the processes by which they are undertaking decisions about where to spend the allocated money that they have. I think that'll be very interesting to find out what the process of that is, because there'll undoubtedly be people, whether you're in acute service, primary care or rehabilitation, all saying, we need some of this, and undoubtedly they do, but how do those decisions get made? So that's what we're interested in looking at next.
We'll be right back. I'm interrupting myself for a second to tell you about long COVID breathing. The fabulous Vicky Jones and I have teamed up to bring you long COVID breathing. We are both passionate about sharing our expertise and experience of the breath and how incredibly helpful that can be with long COVID. We've worked together to develop a course that is specifically tailored to those with long COVID. It's a 6-week course with 12 sessions, all delivered online. The community feel and learning that we're all sharing is such a joy. To find out more information and to sign up for our courses, workshops and other shorter sessions, please check out the link below, longcovidbreathing.com, or email longcovidbreathing@gmail.com to start your breathing journey with us. Definitely. As the study goes on, are you expecting to get any input, or is it that the health boards can use your findings if they want to, but also would be able to ignore it?
No, absolutely. They would very much be able to ignore it. We will do our utmost to communicate our findings and to present them in a way in which health boards can understand what they can do with it. Because sometimes people present research data in such a way that it's not immediately obvious what can be done with it from a health board level. But we'll aim to present and to engage with decision makers and stakeholders across NHS Scotland so that they would understand the implications of what they could do. It's absolutely up to the individual health boards how much they want to take that on. There would be an open door if they wanted to come and ask us to be involved in that decision-making process, but that's very much up to them.
Absolutely, because I think going back to the lived experience, the worry is that the money will be invested without the input of people who have researched or people with the condition that have an idea of what they want, and that's a bit of a concern.
Ideally, if I was sitting in a health board, what would I want to do? I would want to get a working group that pulled together managers and clinicians, but also people with lived experience and academics to form a panel, because each of us bring different perspectives and each of us bring different understandings and learning behind making some of those decisions. So you would love to see something where it was explicitly involving absolutely managers and clinicians. That's obviously essential, but also people from academia who bring a range of different expertise, which I think is not always immediately apparent to those working within the health boards, and absolutely centrally people with lived experience to add to that voice. And I think if they did that, it would really strengthen the decision-making processes that they took, but also it would strengthen understanding among the public at large. If some areas didn't seem to get as much as others, at least there would be a sense that there had been a voice in that decision-making process. I think the risk is if you don't have that voice, if that lived experience voice isn't part of that, then people rightly say, well, we were excluded and nobody asked us, and this is why.
Because like you say, all those voices are important. You need all of them to make an informed decision, don't you? You mentioned the article, which I will put a link to in the show notes because it's absolutely worth a read. You mentioned the precautionary principle, where if some services already exist, then something should be done immediately to help, alongside being informed by research, which is ongoing. Because I think, again, Scotland has put a lot of money into research, which is fantastic. It's really, really important. But I think as people with long COVID, we have felt that actually doing something has been kind of put on hold because the money's been put into research. Whereas surely there are some things that can be done in the meantime?
So absolutely. The precautionary principle is a well-established principle, but I came across it for the first time, or one of the first times, in the work of a professor called Trish Greenhalgh, who's at the forefront of research. She's a primary care researcher at the University of Oxford, and she's been at the forefront of some of the research around about the use of face coverings and masks. And she called on the same principle at the time when face coverings were really not being adopted even by the WHO, and certainly not by the UK government at that point, as a low-risk intervention. So it was not going to cause any harm to the people who were wearing them, and with a high theoretical impact of making a difference. So there wasn't research. And some people have said, we need to do a randomized clinical trial to see if a face mask covering is worthwhile. And Trish's argument was that was just completely unnecessary, because in fact the risk of harm was very low and the potential risk of benefit was very high. Therefore, what we're better doing is implementing it as soon as possible and evaluating the impact as we go. And she's been proven to be absolutely right. We now know the benefit of wearing a mask for the protection of others, as well as slightly for ourselves, but mostly, in fact, for the protection of others is very, very worthwhile. The risk of impact is very low. So essentially, that concept is what we adopted in that paper that we wrote. And is in fact what's happening in practice. Because if you go back to the survey that I talked about, when 14 health boards all said, yes, we are delivering something for people with long COVID, it wasn't that they'd done, and they couldn't have possibly done, high quality randomized controlled trials to discover what was safe and effective for new therapy for long COVID. What they were doing was saying, well, we know what works for people who present with very similar conditions. We know what's likely to have a low risk, because not all rehabilitation is low risk. It's not that they can just do everything, but there are some pre-existing low risk interventions which have got high theoretical chances of being helpful for people. And that's what we should be delivering now, and evaluating what that looks like and how effective, in fact, they actually are. That's what our study's doing in practice. So the precautionary principle is really about delivering therapies which are known to be safe and have a high theoretical chance of being supportive and helpful for people with long COVID. And that's what we were calling on the Scottish Government to support. And their £10 million of funding will go towards that, depending on how local health boards decide to implement and use that money. That money could go towards exactly that. If a therapy or new intervention is untested and has potential to have a safety risk associated with it, then the appropriate place for that is within a clinical trial. So there's two different types of ways in which we can evaluate things for long COVID.
And I guess both are necessary.
Absolutely.
But one is appropriate for rolling out across thousands of people and the other is not at the moment. So there is definitely space for doing plenty of things that can help.
The frustration for people with long COVID is if nothing is being delivered at an NHS level and if they're not able to access appropriate healthcare, then they understandably look elsewhere for anything that can help them. And who could possibly blame anyone for doing that? It's completely understandable. So one example, which has been in the news recently, is people using hyperbaric oxygen therapy for long COVID, a therapy which is known to help divers who experience the bends, and there's good evidence that it can save lives as a therapy for that. It's been more widely tested for a whole range of conditions in the preceding years, for MS and long COVID now, and a lot of other conditions. And by and large, the high quality research studies which have gone into evaluating this intervention have failed really to show that it has a significant clinical impact. Notwithstanding that, you do get people who claim that it has transformative impacts. And that's been the case with people with long COVID. So there's been an upsurge in people going for hyperbaric oxygen therapy because of long COVID and feeling that it has been very, very effective. I've cautioned against that for two reasons, really. One, although it seems to be generally safe, it's not an intervention which is completely safe, and it can have some side effects. And if you've got some pre-existing health conditions, it can be quite dangerous. So it's not a harm-free intervention. And the second is that people who are desperate are investing varying degrees of money, but some spending quite a lot of money on a very untested intervention like this. And we know that one of the big pressures, as well as the health pressures on people who have long COVID, is also the economic pressures due to having to be out of work and everything that goes with that. So spending money on a treatment which is not necessarily effective and potentially could have some health implications doesn't seem like a very wise thing to do. There is, fortunately, in the Karolinska Institute in Finland, there's an ongoing randomized control trial exactly into does hyperbaric oxygen therapy help people with long COVID. So this is a good example of the type of therapy that should be within a randomised safety and effectiveness trial, as opposed to being something which is just being rolled out and used for people. Whereas therapies which are known to be relatively low risk but have good theoretical reasons to be helpful is the sort of thing that we should be rolling out and evaluating on an ongoing basis.
Yeah, absolutely. And like you say, people who've been ill for a long time are getting desperate, and especially if they're feeling like they're not getting anything from anywhere else, they'll sort of try anything.
Yeah, I don't judge anybody for doing that at all. I can completely understand why that happens, but we really need to approach these things with caution.
Probably things to try and things maybe not to try. So when are you expecting to get your first round of results?
So the first learning event for the NHS across Scotland will be the summer of next year. It takes time to gather enough data. So late spring, early summer of next year, we'll have a learning event with the NHS in Scotland. We'll share preliminary results, and a year after that, we'll share the conclusion of our findings. So that's the pattern it's going to look at.
I mean, to be honest, spring is actually not that far away now. When you get your first set of results, it would be lovely to get you or one of your team onto the podcast to be able to talk about them.
We'd be delighted to do that.
Thank you. That would be lovely. Well, thank you so much for coming on today to chat to me. It's been really, really fascinating, and good luck with all the research.
Thanks very much, Jackie. It's been a pleasure talking to you today. Thank you.
Thank you so much to all of my guests, and to you for listening. I hope you've enjoyed it, or at least found it useful. The Long COVID podcast is entirely self-produced and self-funded. I'm doing all of this myself. If you're able to, please go to buymeacoffee.com/longcovidpod to help me cover the costs of hosting the podcast. Please look out for the next episode of the Long COVID podcast. It's available on all the usual podcast hosting things. And do get in touch. I'd love to hear